City of Ann Arbor 2019 Sustainable Ann Arbor Forum, Health Equity, in partnership with the City of Ann Arbor.
Well, thank you all for making the trek out tonight. So our first speaker is Ellen Rabinowitz with the county. She is the health officer for the Washtenaw County Health Department. Using health equity as an organizational compass, she directs all aspects of the department, including strategic planning, budgeting, and day-to-day operations. She also serves as the executive director of the Washtenaw Health Plan, Washtenaw County's indigent health care program that provides access to health care services for low-income, uninsured county residents. Ellen has also served on multiple community boards and is fully engaged in community efforts to improve health and achieve health equity. She currently sits on the boards of Packard Health and the Michigan Association for Local Public Health. She previously served on the boards of Avalon Housing, the Ecology Center, Community Daycare and Preschool, the Washtenaw County branch of the American Civil Liberties Union, the Washtenaw Housing Alliance, and the Washtenaw County Success by Six Great Start Collaboratives Leadership Commission. With that, please join me in welcoming Ellen.
Here's my clicker. I was just going to bring it. So let me start with just a simple description of what public health is, because when people think public health, they often immediately think medical care. But in fact, public health is not just clinical care. It's actually focused on the social determinants of health. That question about, what's the best predictor of your health, wealth. So we're really looking at the social determinants of health and working on ensuring the conditions necessary in the community so that folks can live healthy lives. It's primarily preventive and focused on the health of the whole community. So unlike a doctor-patient interaction where it's one-on-one, we're really focused on the health of the entire community. Just a little bit about how we do our work. 3 main functions. Assuring that health services are delivered in the community, assessing the health. What are the major health issues in the community? And then a lot of what we do is around policy development. One of the best ways to have the largest impact on a community is through policy development. Public health has had a historic role in addressing health equity and social justice. Really, public health as a modern institution arose as a response to industrialization. So advances in health status that have resulted from public health actions, improved sanitation, food safety. Who saw the viral post about the Subway store? You can thank the health department for going in there and ensuring food safety, adequate housing, the abolition of child labor, all good examples of how public health as an institution has addressed health equity and social justice. So what is health equity? What do we mean when we talk about health equity? So according to the World Health Organization, health equity is a state in which all people have full and equal access to the opportunities that enable them to lead healthy lives. It implies fairness and justice, a fair, just distribution of both the resources and the opportunities that are needed to achieve well-being. Sometimes you hear folks talk about health disparities, and we define health disparities as disproportionate differences in health between groups of people. But by itself, disparity doesn't really address the chain of events that produces it. So you can look at different groups and see differences and disparities, but we really want to focus on health inequities, which reflect those differences in population health status, but that differences that are systemic and patterned, unfair, unjust, again, that concept of fairness and justice, and that are actionable, as opposed to just random differences or those caused by people who become ill. So it's really a systematic approach. Why does health equity matter? Well, we just learned why health equity mattered in all that data that we learned about in that quiz. So we looked at life expectancy rates. In Washtenaw County in 2017, the average age of death for whites in Washtenaw County is 76 years. For blacks, it's 65 years. Think about that for a second. So the average black resident of Washtenaw County is not going to live long enough to collect Social Security that they've worked their whole lives to collect. Infant mortality rates, another place where there are glaring disparities. So the most recent data we have is from 2014 to 2016. Whites, 4.3, blacks, 16.4. So almost a 4% difference in the rates. In addition to that, black babies are twice more likely to be born prematurely or low birth weight, which of course are indicators and risk factors for infant mortality. These are just two pieces of data. When you look across all of the data that we collect, you see that black people have dramatically higher rates of sickness and death compared to most other racial and ethnic groups. Couple of examples, and this is data that comes from a community survey that the health department does. Ever been diagnosed with diabetes? Blacks 11%, whites 8%. Ever had a stroke? Blacks 4%, whites 1.8%. Adults who have health insurance, blacks 98%, whites 92%. Remember that question about does health insurance determine how healthy you are? In fact, we see these differences despite the fact that blacks have higher rates of health insurance in our county. How do I go back? Wilma, stop this crazy thing. Okay, here we go. So this is a framework that we have borrowed from our colleagues at the Bay Area Regional Health Inequities Initiative. I'm going to stand up and I'll talk loudly. I've never been told that I'm quiet. So here's the stuff I've been talking about. Mortality, disease and injury, risk behaviors. And these are the things that public health has traditionally focused on. These are the things that healthcare's focused on, that case management, health education, health behavior. And this is sort of the current public health practice, focusing on all these downstream factors. And what we're trying to do is flip that on its head and really focus more upstream on the living conditions. So as I said, focused on the social determinants of health, the physical environment, the social environment, economic and work environment, and a lot of community capacity building, community organizing. Here's that policy piece, looking at institutional equities, and when I'm done, Felicia's going to talk to you about what Washtenaw County's doing about looking at its institutional inequities, and then finally on social inequities, class, race, immigration status. So we're really trying to move upstream. And like I said, I credit our colleagues at the Bay Area Regional Health Inequities Initiative, Bar High as they call themselves, who developed this conceptual framework to really illustrate the connection between social inequalities and health, and to really focus attention on the measures which haven't characteristically been within the scope of public health. So what does that mean here locally? As Missy read in my bio, we really use health equity as our organizational compass, and that includes 4 different things that we do. One is mobilizing data. That's what we do in public health. We're data-driven. We look at the data to tell us what the issues are. We prioritize those upstream factors, those social determinants of health. We work across sectors and have and engage in community empowerment work. So here are a couple of examples of how in our health department we're advancing health equity. Mobilizing the data, but we're not only mobilizing the data, we're really trying to change the narrative. We're trying to change the way we look at the data so we can get at the these issues of inequity. So instead of asking a question like, how do we create more green space, bike paths, farmers markets, which of course is high on the agenda of the Ann Arbor Sustainability Office, and it should be, but perhaps we could also ask the question, what policies and practices by government and commerce limit access to transportation or recreational resources or nutritious food in neighborhoods where health is the poorest? So, really changing the narrative and changing the questions that we ask. Instead of asking, how can we connect isolated individuals to social supports? Of course, we want to ask that. But in addition, let's look at the institutional policies and practices that maintain rather than counteract people's isolation from social supports. As I said, another aspect of our work is really focusing on those social determinants of health, economic, social conditions that influence the health of folks, communities, and jurisdictions. And so, it might not seem like a piece of work that public health would do, but, we're involved in assuring safe, affordable housing, quality education, job security, et cetera. One of the things we do, because we're involved in those issues, we're reaching across sectors and creating cross-sector partnerships. Just a couple of examples of the way that gets played out. We worked on a report called Reducing Youth Arrests Keeps Kids Healthy and Successful. We did this report with the Human Impact Partners. It was a health analysis of youth arrests in Michigan. The folks from the Michigan Council on Crime and Delinquency were involved. Not necessarily something you'd think that a health department would be involved in, but we're really concerned about it. And now we're going to, looking at what other communities have done, we're starting to look at ways that we can reduce youth arrests, whether it's, working with law enforcement and the justice system to create a system of civil citations, for instance, whether it's working with the Michigan Council on Crime and Delinquency around raising the age at which juveniles are adjudicated as adults. Another example, and I'm not going to steal Paul's thunder, I can't wait till you hear what Paul has to say, but we've done a lot of work as a public health department in support of immigrant rights. And that includes starting in January of 2018, when President Trump announced the Muslim ban, we launched an All Are Welcome Here campaign to make sure that our immigrant clients knew that our health department, our service delivery was open to them. We have done a number of things, including working with Paul and other researchers on looking at the health impacts of increased immigration enforcement. Another issue that we are working on, food security and food systems. Finally, and leading into my discussion about our community organizing work, we're in partnership with the Sycamore Meadows Tenants Association. So community empowerment work is a big focus of how we're doing our work now. We've always been engaged with our community. We do surveys where we ask members of the community what the major health issues are. We hold focus groups. But we're trying to change that and really work together in community with leaders of the community who know best what issues there are in their that are going on in their community. So in terms of this spectrum of public participation, we're really moving from this inform to consulting, involving, collaborating, and finally empowering. So in Sycamore Meadows, where we have started some work, we went out and met with a community group, and we came out with our data, and we said, here's what the data's telling us about what the issues are in your community. And the residents said to us, yeah, that's all well and good, but really our housing conditions are abysmal, and that's what we really need to work on. And we said, okay, so what do we need to make that happen? Shout out to Marta and to Joanne, who are two community leaders that are working with the health department in their neighborhoods, the New West Willow Neighborhood Association and in Whitmore Lake. We're proud partners with those two groups and a whole host of others. Okay, connect with us. There you go. So that is a whole big, long lesson on health equity done in less than 15 minutes. It's a big topic, and but happy to entertain any questions that folks have now or after.
Sure. Can you please join me in thanking Ellen for that fabulous? We discussed in terms of format, what we were going to do is take any really burning clarifying questions right now, so we have more time for kind of group discussion. Does anyone have a burning question? Okay, excellent. Speakers, can you stay close to your mics?
Oh, sorry
I know,
about
Ellen,
that.
I'm shaming you, but no.
I've never been told that I'm quiet.
Well, it's because the mics don't pick it up for the recording. So our next speaker, you can switch the lead in. It's either doctor or commissioner, depending on where we go. But it's Dr. Felicia Brabec. She is a county commissioner for Washtenaw County. She's held office since October 2011. This is her first public office. We're glad to have her for sure, for those of you who know her and her work. Dr. Brabec served as the chair of the board for 2 terms and chair of Ways and Means for 4 terms. Currently, Commissioner Brabec serves on the following boards and committees, and get ready for this, because I don't know how she's even here with all of this. The Action Team for Racial Equity, Coordinating Funding Leadership Group, Community Mental Health, Board of Public Health, Community Corrections, Affordable Housing and Equity Leadership Team, Statutory Drain Board, and the Health Emergency Response Coalition. I think she probably walks the walk, based on what I'm seeing here. Commissioner Brabec earned her doctorate in clinical psychology from the Illinois School of Professional Psychology, her master's degree in clinical social work from Boston College, and her bachelor's in sociology and anthropology from St. Mary's of Notre Dame. She is also a local small business owner who runs her own private practice here in the county. So please join me in welcoming Commissioner Brabec.
Hey, Missy, I am, there are many things I can do.
No, you just have to go forward.
Technology is not, oh,
Just click.
okay.
Yeah, we made it so easy.
Wonderful. Thank you. That is super easy. So I first want to say it's so exciting to see so many folks here, especially on a night like tonight when we're poised to get a lot of inches of snow. And I also want to thank 2 of my colleagues for being here, Jason Morgan and Katie Scott, both for being here. For those of you who live in Ann Arbor, these are 2 out of your 3 commissioners, so they are here in the room. So that's fantastic. So Ellen really teed us up to talk a lot about what we're doing here in the county. She spoke specifically about the health department, and it truly is really exciting to work with the health department. I mean, some of the things that under Ellen's leadership, we have really switched, I think, from more of a traditional kind of public health to really taking this a community perspective, and it has been remarkable to watch the actions not only of Ellen and her entire team, but also of the Public Health Board. And I just said to Ellen, I think yesterday, it's like my favorite board meeting a month, because the discussions are so amazing, and we're doing things that are meaningful for the community and taking stances on things that I think most boards of public health, frankly, don't do. And so it really is amazing. But part of why we started looking at the county at inequities was work of Ellen and some of our other directors, and we started having conversations about moving the needle and knowing that we had inequities that we were seeing, but not knowing, or knowing that the interventions that we were actually had in place weren't doing what we actually wanted to do, or to the level. And so we decided to take a different look at things, and so really started to look at how we want to form this differently. And what we decided to do was focus on something that is a little bit different than your typical kind of diversity and inclusion, and we are operating under the auspices of something called targeted universalism, which means that we are choosing to really focus on race, and Ellen shared some of those determinants that you heard about based on race. And what targeted universalism says is, hey, we're going to start with this sliver, we're going to start with race, understanding that intersectionality is really important, And part of all this, and we're not doing that to the detriment of these other intersectionalities, but this is where we're starting. And so we made that decision as a county to do that. And so from that, we had to start to really do some definition building, which is what Ellen did as well. So we started with, what is equity? Like, what are we really looking at here? So this is where we started from. So that equity is not, that neither a person's race nor a person's address can predict their outcomes in life. And that's one of the questions that we all just answered. I wish there was like a post test, like maybe like 5 different questions that we got to answer. I loved it. I thought it was so neat. But part of what we really wanted to look at was, again, having this place where we're all starting and these same definitions. And so looking at institutional, looking at individual, looking at structural racism and all these different ways, and looking at what can government do as government, how have we added to these issues, and what policies do we have in place that keep racism continuing, and what things can we do differently so that we can start to eradicate some of that. I mean, we all understand that we're up against, centuries-long traditions, if you will, in our country, and so know that we have a heavy lift, but also know that there are things that we can do to really move the needle. So that's what we're trying to do. Like, look at the 3 different kind of layers and levels, and where can we really intervene? 3-4 years ago now, we had, and some of you may have been there, Ellen was there for sure, we had an equity summit. And at that equity summit, there were about 300 community folks. Some of you may have been there too, like I said. And there were some suggestions that really focused on that individual racism. So do the bias training that a lot of you might have seen that Harvard does. You can just hop online and do it. It's really interesting to do if you've never done it. You'll learn a lot of things about yourself, and that was one of the things that we were focused on in there. But we were also talking about some of the structural and institutional things. We were looking at health and education, mental health, public safety, housing, education. So looking at those systems and what those systems are doing or are not doing to perpetuate these things. So because of that, this is more about the institutional racism and how, again, we at the county can think about what we have done or how we have added to, and then what we can do to address how we have perpetuated this. One of the things that folks have heard about is redlining. Many folks don't really know that has happened here, right in our neighborhoods, in Carytown, in Ipsy, Water Hill. I mean, there are lots of places right here where that has happened. And so that map, though, is not of Ann Arbor, just to be clear. But we're trying to look at all of the different impacts that we know institutional racism has on the clients who we get to serve, who come in and are seeking services from the county. And they're varied. I mean, there could be financial, emotional, physical, social. And so one of the things that I am grateful for in being able to be a county commissioner is being able to work with folks on some of those bigger issues, like when folks come in to see us. But then in my private practice, I work with people on the individual, often the emotional trauma-based place. And so I feel lucky that I get to work in both arenas in terms of policymaking, but also then on a micro level with folks as well. So Ellen touched on this, but this is what has driven our work. There are so many great things about our cities here and our county. There are the list on the left. We're named like the #1 most educated city, and it's maybe the top 5, or it was like the millennials love living here. Oh, there, the #1 city for millennials, and we're #1 in our county for health factors. I mean, there are so many things that we do really well. However, there's another side to that coin. And part of it was what Ellen was talking about. I mean, she talked about the difference between life expectancy between Black and white men. For Latinx, I think it's 16 years. So 16 years is a life expectancy difference. So that's another thing to add. We know in terms of education, there's a 30 to 40 point difference in terms of test scores for students on one side of the county and another. We are the 8th most, for our size, we are the 8th most segregated, economically speaking, area throughout the country. Our housing market, many of you, I don't know if any of you, or many of you may have experienced this. I know someone who 3 years ago was trying to buy a home and put an offer in that was $30,000 above asking price and didn't get the house. So, and that was 3 years ago. And it's just gotten, increasingly more expensive to live where we are right now. And we are in the bottom 8% in terms of upward income mobility. And again, we talked about that question. What was it, the last question? About, it's income, right? And wealth that determines health. And so we have some work. We have some work to do. And so that has really led us to the work that we've done, and we've partnered with GARE. Let me find them. Here we go. So the Government Alliance on Race and Equity has really worked with all of us meaning folks at the county, to create a racial equity framework. And in September of last year, we the county board, passed a racial equity policy. And what that policy is to do is to set the framework for us to be able to, in a much more formal way, address some of these inequities. And so and we're looking internally. So we're looking at everything from how do we hire? How do we post jobs? Where do we post jobs? Are we asking for certain levels of education that are unnecessary, that aren't needed, but we're weeding people out? Unnecessarily so. How do we promote internally? We're having every department do a racial equity action plan. So each department, and Ellen's her department's already light years ahead of other departments, as you could tell. But what they're going to be doing is developing plans to really take a look at, because each department will know the nuances of their departments, how they can move this vision forward. And so we're going to be working on those this year. Every single staff member will be trained in an intro to racial equity. We have 1,400 employees, so they will all be trained. We have about 60 who have been trained now. Yeah, is that right? A little bit more, I think, because we had trainers get trained. Right. So we have that training that is happening. The thing that I love about that training, I think I've done that training 3 times. Every single time I learn something new, like either from the history that I'm hearing or about myself and the engagement with the work. And that's one of, I think, the most amazing things about this work is the potential for growth in all of us when we get to do this. So that's what the county is basically doing. I did want to share a couple of intersectionalities because of the work that I get to do in mental health. So it's just I've done it for a couple of decades in private practice, but I also get to sit on the CMH board. And one of the things that we're really looking at is the intersection of folks who go to, and I'm sorry, we have lots of acronyms. CMH is Community Mental Health. Folks who receive services from community mental health and the intersection with public safety in the jail. And so one of the things that some of you may remember voting for or against is the public safety and mental health millage. And so part of that work is really looking at that intersection. And so I have a couple, Alan talked about data, and so we've been gathering a lot of data to really understand the nuances of that, to be able to figure out how we want to respond to that. And so some of the things that we know are inmates who are known to CMH have a much longer stay in the jail than those who don't. So much so that inmates who are known to CMH stay on average 27 days. Inmates who aren't, 11 days. So that gap, to think about what's happening for folks who are staying in jail that much longer, who might not know how to navigate the system, or might not have the skills, or might be ill, and might not actually belong in jail, but somewhere else. We also know that the readmission rate is notably higher for folks who are involved with CMH. So if you're involved with CMH, the readmission rate is about 58% versus 29%. and so almost double. And so again, the Diversion Council is really starting to take a look at we're missing some opportunities here. If it's almost double in terms of folks ending up back in jail, what aren't we doing to be able to help those people? And finally, there's a disparity between race. And so what we know is that our total inmate population is about 49.5% Black, 47.8% white. But in terms of inmates known to CMH, it's 42% white, but 56.5% Black. And so again, what's happening there in terms of all that intersectionality? And so the sheriff and our director of CMH are really helping a group of us take a look at all of those things and try and figure out what interventions need to happen for our community to be able to change and shift those numbers. So that's a little bit about what we're doing on the county side.
Thank you. Are there any burning questions? Okay.
Burning questions are good.
They are good. We're going to go thought-provoking shortly. All right, our last speaker is Dr. Paul Fleming. Paul is an assistant professor in health, behavior, and health education at the University of Michigan School of Public Health. He previously worked as a community health Peace Corps volunteer in Nicaragua. His research today focuses on the social determinants of health, as we heard about earlier, with a particular focus on developing and evaluating interventions in poor and marginalized communities in Michigan and abroad. He uses a community-based participatory approach with Latino immigrants to examine how policies and discrimination contribute to poor physical and mental health outcomes. He holds his PhD from the University of North Carolina and a Master's of Public Health from Emory University. Please join me in welcoming Paul.
Well, thank you everyone for being here, and thanks to the organizers for inviting me. It's definitely an honor to be able to present with such a great panel, and also to live in a county where this type of work is going on. So definitely my presentation, I would say, is more of kind of a sliver or a slice of health equity that gives kind of an example of what's going on in our county with a certain, some of our neighbors, as opposed to sort of the larger overviews that was just given. This work that I'll talk about is definitely a collaboration. So I'm one person here, but there's a lot of different people that have come together to do this work. Ellen is one of them at the county health department, also the Washtenaw Health Plan, Packard Health, and then we also this work involves CHAS, which is a federally qualified health center in Detroit, so outside of the county. And here are just some of the names, which includes Ellen on here, who have participated. So this research really stemmed from the 2016 election. So in the aftermath of the 2016 election, a lot of the health department, a lot of folks in the county were noticing changes in the clients that they were serving that were immigrants or part of immigrant families. As we probably all know, in the 2016 election, there was dehumanizing and anti-immigrant rhetoric that still goes on today. Shortly after President Trump took office, there was an expansion in the number of ICE agents. So ICE is the Immigration and Customs Enforcement officials. And we saw in Michigan a 40% increase in detentions in the first year of the presidency. And then the other thing that was going on is there was an expansion of the criteria for detentions and deportations. So largely under the Obama era, while there still were many detentions and deportations under Obama, they were focused primarily on targeting people with a criminal record. And after Trump took office, there was an expansion to consider basically anybody. And so it made almost anybody who was an immigrant living without documents a target for detention or deportation. So we saw anecdotal evidence of a chilling effect. So this was noted here in Washtenaw County and then also across the country. So clinics were starting to report that their immigrant clients were not showing up for appointments. And they were noting that their clients, when they were showing up for appointments, had heightened anxiety or concern. And then, CHAS, this clinic, Packard Health, which those of you not familiar, is a federally qualified health center here in Washtenaw County. and the health department as well, we're noticing all of these changes. So just want to highlight, so what we're talking about here, the primary people affected are undocumented immigrants. So those are people who are living without legal authorization to live here in the U.S. But it also extends beyond just the undocumented immigrants to also include their family members. So this could be citizen children, a citizen spouse, but they're also worried and concerned about this issue. So in the state of Michigan, we have about 130,000 undocumented immigrants, and the vast majority of those live in the kind of metro Detroit, Washtenaw County area. Undocumented immigrants are excluded from Medicaid, so they're not eligible to receive it. They're excluded from the health insurance exchanges through ACA, and many times they're excluded from employer-based insurance. Federally qualified health centers and then also the health department, so the Washtenaw Health Plan, help fill that gap and really provide health services for the immigrant families that are kind of neighbors here in our county. And those are also considered highly trusted resources among immigrant families. So that really brought us together to ask the question of what changes have healthcare and social service providers seen since the 2016 election? So what we did is we conducted research with staff members. So we talked to providers, enrollment specialists, community health workers, patient advocates, front desk staff, drivers, to see what have they been seeing. So these were all qualitative interviews, which means that we recorded what people said, transcribed it, and then kind of went through some analysis procedures to come up with what we felt like were the important themes from the research. So we found 3 interrelated themes here. So the first one is that these staff members were noticing increased and pervasive fear of deportation and family separation among undocumented immigrants and their families. The second theme is that the fear has resulted in fractures in community cohesion. And then we also saw this thing we're calling strategic behavior change. So undocumented immigrants were making changes to their behavior as the result of what they were experiencing. So I'll talk a little bit about this first theme of increased and pervasive fear. So we see that undocumented immigrants and their family members feared being separated from their family and friends. One patient advocate at CHAS, which is in Detroit, said they're fearful. They're so much more fearful now than they were 2, 3, 4, 5, 10 years ago. Huge, huge impact, huge difference, talking about since the election. Most folks, staff members, said that this fear was most acute in that immediate post-election period. Whoops. So Vanessa, who's a provider at Packard Health, said, we were seeing straight fear. Between the election and the actual inauguration, I think was the worst because there was a lot of, we have no idea what's going to happen, and just a lot of fear. People would come in and say, I'm afraid. So those were her patients that she's referring to. Some definitely noted, was this fear actually due to increased detentions and deportations or simply the rhetoric that was being spouted by politicians and in the news media? So Brian, who's a medical doctor at CHAS, said, the rhetoric that comes out from Donald Trump, I think the patients definitely feel it. It's not even just the ones that are undocumented. I think the entire community feels it. So this is really highlighting that it is certainly the undocumented patients, but it's also their neighbors, their family members that are really fearful that those community members, their neighbors, might suddenly disappear, get detained, deported. So that fear was community-wide. The other thing staff members would note is that this deportation is not new in the Trump era, but that the rapid changes that occurred after the inauguration created this real uncertainty and fear. So Brian again says, it just doesn't seem like there's any rhyme or reason, and what makes me more nervous is the rhetoric creates fear, but now the inconsistency creates more fear. the inconsistency of ICE agents and how they work, it's paralyzing. And I just want to highlight that word paralyzing, because Brian sees the majority of his patients are from immigrant families, and he's seeing this paralysis that contributes to folks not being able to leave their house, not being able to get the services or resources they need. And that idea of paralysis came up several times. So I want to switch to the second theme that we found. This wasn't as prevalent as the first and third theme, but I think it's worth noting. So we noted fractures in community cohesion as a result of what was going on with the changes. And what we mean by this is we heard about fractures between the immigrant community and non-immigrants, and then also fractures within immigrant communities. And I'll tell you more what I mean by that. So for the fractures between immigrant communities and non-immigrant communities, there were reports of increased racism and discrimination against immigrants. So one of the receptionists at CHAS, which was in Detroit, but we also heard similar stories here in Washtenaw County, said, a lot more people seem to be coming out more racist and more against Hispanic communities. So I think some of them are more like, they don't want to go out to stores or do anything where they're going to have that complication where someone says, well, where's your green card, or where's this? And they got to get nervous. And so she says, yeah, I think the election affected the community a little bit. And just to note, we also heard about incidences between clients at the provider sites where a non-immigrant might say something offensive to an immigrant family. And so that was also concerning. And then the other fracture is fractures within immigrant communities. So this is one of the patient advocates at Packard Health says, really highlights kind of how this happens. So she says, after a family member has been detained by ICE, that family is seen as in a way as tainted. So their communication and their contact with other community members, family members, or friends, they're kind of like the plagued family. Oh, ICE has been to that house, we're not going to associate with them anymore. Now, of course, that's not the case. Not everybody treats that family that way, but just to note that there is a concern because somebody would want to protect their own family, make sure that nothing happens to their family. They may not want to associate with this other family that has been targeted. And so that's another thing that was reported. So getting to the third theme, which is really relevant when we're talking about kind of the social determinants of health and how this impacts health, is that all these staff members were reporting that their immigrant clients or clients from immigrant families were adopting this strategic behavior change. What we mean, and so this behavior change was a strategy to limit the possibility that they would be deported or detained. And ultimately, this was about family separation. So not necessarily family separation at the border, but the idea that if any member of your family gets detained or deported, they're separated from their family, the ones they love, right? If they're sent back to their home country, they're no longer able to be part of the family that they care about. And so what we saw, for example, is that clients were limiting travel to appointments. So this included clinic appointments for a medical issue, but also appointments where they were going to be signing up for government benefits that they were eligible for, or perhaps their citizen children were eligible for. They were limiting trips to the grocery store, to parks, et cetera. And they were avoiding government services like WIC, or like I said, enrolling their citizen children in services. So this limiting visits to the clinic. So this is what we heard about. A lot of the clinic staff said that there was fewer clients showing up immediately after the election. So those no-shows happened a lot more frequently right after the election, right after the inauguration. So one of the enrollment specialists at the health department said, once elections took place and we had a new president in place, you had clients that weren't coming. I mean, the office was, again, literally empty for a couple of weeks, at least because people were afraid to come in. And this woman's office is not typically empty, so this was definitely a noticeable difference. The other thing that is continuing to happen is increased no-shows when immigration enforcement occurs. So one of the receptionists at Packard Health said she was talking to a woman on the phone. She said, I had a lady, she was very honest. She was like, I'm not going out. I heard my grandson told me that immigration was doing a round and I'd just rather stay home. She's like, yeah, I'm going to call back to reschedule. So in that case, she had heard about from her grandson that there was an immigration raid or an arrest or detention somewhere nearby. And so she decided not to leave her home for that day. And we heard about that at all the different sites where when folks hear about an immigration arrest happening, then they sort of go into lockdown mode and try not to be visible. And here in Washtenaw County, there's a kind of informal network of notification so that folks can protect themselves when ICE agents or other agents are out, and the same thing happens in Detroit. So people are getting the word, and that's a good thing because they're able to protect themselves, but it also means that they're not able to go out and get some of the needed services at health departments or health clinics. This is a quote from one of the community health workers in Detroit related to limiting visits to the clinic, and I think it really exemplifies how this impacts health. So this community health worker specifically works with clients who are living with diabetes. She says, I have a diabetes patient that barely ever leaves her house. She's just scared. She's really, really scared. The fear makes their A1C numbers go through the roof, which is the kind of main indicator for diabetes, because they're stressed out all the time. They're always looking over the shoulder. Sometimes they'll go a week or two without medication because she says, I can't find anyone to take me, or I can't find anyone to pick it up for me. Or because they just don't feel safe enough to come out. The other thing we heard about, so that was kind of attending actual health services, but there are also some families and some immigrant neighbors we have in the county are limiting trips to the grocery store or parks. So this has a potential impact on food security with folks maybe not being able to get sufficient food that they need. So one of the enrollment specialists at the health department here in Washtenaw County said they're stressed, they're depressed, they have anxiety. People don't want to come out of their house. They're afraid to go shopping for groceries because they don't want to put themselves at risk. Another person at the health department commented about a family she was working with, and they've limited themselves to go to the grocery store once every 2 weeks. That's the kind of extent of the exposure they're willing to have. And when they run out of food towards the end of those 2 weeks, they just make do. And that family has children, so obviously those children are affected by that food insecurity. Just the other thing to note, we also heard about, many of these staff we talked to become close with some of these families, know the families intimately, and some of them talked about how before, they might get together for a birthday party at a local park, get together at the playground, but they were starting to avoid these more public spaces because they were just afraid of kind of coming together as a big group of, people who look like immigrants coming together and potentially exposing themselves. And then the final piece is that, enrollment in services like WIC, Medicaid, other government services, there was a concern about giving their name to a federal government program. Now, I want to be clear, in many cases, some of these undocumented immigrants are not eligible to enroll. So they may not be eligible, but one of their family members may be eligible, may be a citizen or have legal permanent status and is eligible to enroll. And so we were hearing about the cases where, if one member of the family is eligible but others are fearful of traveling, they may not actually expose their family by giving their name and phone number and address in this way. So Jimena, who is a WIC specialist in Detroit, said, back in the year or so, they stopped coming to their appointments. We have clients who would call us and say they don't want nothing to do with WIC only because of immigration. So they were worried about enrolling in WIC, and they might get kind of caught up in immigration. And then the other thing to note is that the Trump administration has proposed a public charge rule, which changes the rules about who, could be eligible for citizenship status or legal status, and saying that if anybody has received a public benefit such as WIC or housing vouchers or Medicaid, that could make them ineligible to be a legal resident. And so what we saw there is that kind of had a widespread effect on all immigrant families, because the uncertainty related to what that would mean exactly just caused a lot of folks to either not enroll or drop out of programs that they were already receiving. So all this uncertainty is having a fairly large effect. The staff that we talked to, it was clear across the board, they're seeing this chilling effect, right? That health services, health utilization, health promoting behaviors are being curtailed because of the uncertainty and the policy changes since the 2016 election. We see that the current immigration enforcement system is having devastating effects on families and communities, and ultimately impacts public health. It's really important that I note that these devastating effects, yes, are primarily targeted on undocumented folks, but remember that those undocumented folks play key roles in our neighborhoods, in our community, right? So when that individual may be detained or deported, that's somebody's soccer coach, somebody's neighbor, et cetera. And so it has this ripple effect across the entire county. So being in public health, we look at problems, but we also want to solve them. So we've been talking about with Ellen and with the other partners about what do we do? How do we address this issue? This is primarily an issue related to policies at the federal level, but there are things that we can do locally. So first, making sure that we're creating welcoming spaces, which Ellen talked about a little bit of the All Are Welcome Here campaign at the health department, which is extremely important. And I just want to note that the health department here really is leading the way nationally on how a health department may respond. Ellen has been presenting at national forums on what the health department here is doing. So they've done an excellent job creating welcoming spaces. And also our clinical partners are really making a strong effort in that regard too, but making it clear that if police or ICE show up at a clinic, that they're not going to hand over their patient records or hand over or clients, making clear that they're welcome, and there's other strategies to make sure it's a welcoming space as well. Everyone on our team thinks it's really extremely important that we are speaking up, and that as these immigration debates are happening locally and nationally, that we're sharing data and stories about how this immigration system is impacting health. Obviously, we focus on health. The immigration system has an impact on a lot of different areas, but making it clear that this is a public health issue that is impacting the health of a lot of folks in our country. In this particular moment, when the immigration policies are what they are, we as health professionals need to really be adapting to find creative ways to reach out to immigrant clients with services. So some of the things we've talked about is first off, using folks like community health workers to go to people's houses to reach out. We've talked about telemedicine or telehealth, which is a way that you can provide health services over the phone or through video chat services. And then also just thinking about expanded transportation to be able to bring folks in. One thing that I didn't really mention much is undocumented immigrants in the state of Michigan are ineligible to have a driver's license. But we know this is a very driving-heavy state, right? So luckily, Ann Arbor has fairly good public transit, but nonetheless, it still can be challenging to get around. So without a driver's license, every time that they might be on the road, they have to put themselves at risk because you really can't live or have a job without driving on occasion. So that's where we see expanded transportation might play a role if we can be the one providing the driving services. And then finally, making sure that public health institutions, which includes clinics, includes health departments, includes researchers like myself, are getting involved in the advocacy side of things, pushing for family-friendly immigration policies that consider public health. As we all know, there's no simple answer to immigration policy reform, but we do need to be thinking about the health impacts and how these can be family-friendly and not kind of focused on separating families.
Well, please join me in thanking our speakers once again.
This program was recorded on January 17th, 2019 at the Ann Arbor District Library.